Great. So good morning, good afternoon, or good evening even to all of you. Welcome to our kickoff at the SYSTAC Capacity Building webinars. This is our very first one, and we're really excited to have you all here. Today's session is titled Systems Thinking from Theory to Practice, and we will have actually two sections of the session. First, we will have Dr. Aku Kwame, Technical Officer at the Alliance for Health Policy and Systems Research, who will be setting the scene and explaining why we are all here and what we are actually embarking us on. Then Dr. Daniel Kogels, a project leader at here, where I also work at the Swiss Tropical Public Health Institute, will be setting the scene on what is systems thinking and also a little bit what we are here. And then we will have a chance to have a bit of a short Q&A with the two of them. Then we will be moving into the presentations from the, Professor Joanna Occhipinti and Professor Shamsa Rizwan, who I'll be introducing in a minute. And I forgot to say, my name is Carmen Sant. I also work at the Swiss Tropical and Public Health Institute, and I'm really excited to be hosting or moderating today's session. And having said that, I would like to hand over to Aku, who will be introducing us and opening the session. Thanks so much and welcome everyone.
Thanks very much, Carmen, and good morning, good afternoon, good evening to you all. We're so excited to see you and that there are so many of you here, a lot of familiar faces, some good friends, and delighted that all of you have joined us this morning. So very briefly, I just want to welcome you all on behalf of the Alliance for Health Policy and Systems Research and our work on systems thinking, and introducing you to the Systems Thinking Accelerator. We call it SYSTAC. So what is SYSTAC? SYSTAC has three main objectives. It serves as a platform for systems thinking science and practice. We want to come together to be able to define or redefine the field and exchange experiences with one another. It's a community. We want to build community that is engaged in the tools and the thinking and the approaches and methods of systems thinking, application, not just theory, and really having a place where we can convene and where we can support capacities and build a critical mass of people who are engaged in systems thinking. It also seeks to be an amplifier of applications of systems thinking in low and middle income countries, really around promoting and advocating for greater use of systems thinking in policy and in practice. What have been the origins of SYSTAC? How did we end up here today? As many of you know, in 2009, the Alliance launched a flagship report on systems thinking for health system strengthening. That's a report that many of us have drawn on and many of us continue to use in our work. And between 2012 and 2014, the Alliance supported the publication of two special issues. The first was really around strategies for systems thinking in LMICs. The second one was really around showcasing examples of how systems thinking has been used in LMICs. But we found that there was still a dearth of applications that we could draw on. And the literature is still quite thin in terms of examples and exemplars. So in 2019, the Alliance launched projects looking at systems thinking to strengthen district health systems. And we've been doing that work with our friends at Swiss TPH. And this was work in three countries, Pakistan, Botswana, and Timor-Leste, to try to apply systems thinking to routine work for district health management teams. And today, one of our presenters, Dr. Shamsa, will be speaking to us about that experience. But more to the point, there's still a need for emphasizing systems thinking, particularly in applications, particularly in policy and practice. And so it remains a focus of the Alliance and an integral part of our new strategic plan. We have recently published a commentary on the need to sort of build the field of systems thinking, and we'll drop that link in the chat for you to read that paper. So the work around SYSTAC is to sort of build on those foundations that so many people have been involved in and really set a path for systems thinking. So when we speak about SYSTAC, who are we referring to? So as we've been starting, we've started with 5 regional institutions. We have the University of Costa Rica, we have the Ghana Institute of Management and Public Administration, we have the George Institute in India, we have the University of Manila in the Philippines. And in Switzerland, we have 3 organizations. We have the Alliance, we have the University of Geneva, and then supporting the capacity stream is the Swiss Tropical and Public Health Institute. But we want to expand SYSTAC, and while many of you have been involved in some of the needs assessments that have been done by those regional institutions, we want to invite as many of you to belong to this community of practice. And so for those of you who indicated in your registration that you would like to join, we will follow up with you after this webinar on an invitation to join us online, where we have a small but growing community where we want to think together. We want to document practices. We want to capture examples. We want to build theory. We want to support capacities. And so we're doing that in this online community, which is called the Hive, the Alliance Hive. And we're also working towards having a global public meeting in October, where that would allow us to engage more people who've not been with us to date. And so in terms of today, why are we here? We heard from many of you in terms of what were the needs around systems thinking application. And so the webinars that we're conducting today and next week that are being hosted for us by our friends at SwissTPH are really in response to the findings from those needs assessments. And we found that there were some common themes that emerged across the regions. There was a desire for skills building in terms of competencies, but also in terms of sharing knowledge and experience. There was a desire around building awareness. Many people are doing systems thinking, but don't know that they're doing systems thinking. So how can we advocate to clarify what we mean when we're speaking about systems thinking, but also advocate for the mindset shift in the broader environments that we work in that can support us in applying systems thinking. And then finally, reckoning with the challenges. Systems thinking is challenging. How do we do it in difficult contexts? And how can systems thinking sort of move out of the realm of just being an academic endeavor to being much more practice focused and supporting policy change? So we want to welcome you. We want to wish you fun in this time that we'll spend together, but also, deliberate. This is really a sort of a free space, so we invite you to just engage as much as possible and continue thinking with us in the coming months as we move towards our global meeting. With that, I'll stop and I will hand over the floor to Daniel. Thanks so much, and Daniel, over to you.
Hi, sorry, that got me a little bit by surprise. I was okay. Can you see the slide? The slides? Yes. Okay. Okay. Thank you, Aku. Thank you for the introduction to SYSTAC, and again, welcome everyone. I'm really excited that this is finally happening, and it's been like some work till we got here, but I think now we have a strong foundation to move ahead with SYSTAC. So what I was planning to bring in these 5 minutes is some of the ideas and the thinking that we have done so far in terms of why we need system thinking and how is it useful and why we need SYSTAC and how we bridge this gap between the theoretical basis of system thinking, which is quite broad, to actually applying it in real life settings, in health systems all over the world. And just before I go there, just to say that I'm here just representing, so it's a group of people working at SwissTPH, and there are more people in addition to the ones that are in the in the picture. So just to say that this is not me, it's a team effort. So the first thing is that we've been all struggling with interventions that they work fantastic, they work perfectly in some settings, but then when they are taken to other settings or when they are implemented in real life health systems, then they fail, and people get frustrated, and people say, oh, but why this is happening now? Like, I can't understand this, and what we think is that many of those times, what happened around that is the system, is all the contextual factors, all these things that you haven't thought through when you were bringing the intervention, those things are the ones that are happening. So in a sense, what we want, how we see system thinking to be useful is that it helps you identify all those things that may influence how your interventions, how your systems, how what you are doing to improve health works or not. And we like to bring one example from Tanzania that we did at SYSTAC on access to malaria, and it was a study done in 2012, so kind of old now, but what they did, they tried to understand, like, from, for example, in this case 1,000 malaria fevers, how many of them would get like the actual treatment that they would need, and they saw that some of those people, some people with malaria, they didn't even seek care. Some others, they didn't seek care in 24 hours, when the treatment is most useful. Some of them, even if they access in less than 24 hours, they went to a facility that it wasn't the right facility to go to. And even if they come to the right facility, sometimes nurses and doctors and clinicians in those facilities, they don't diagnose correctly, and they don't provide the adequate treatment. But from those that were provided the right treatment, they went to the pharmacy, and there were stockouts of antimalarials, and they couldn't get access to the antimalarials. But even from those that got access to the antimalarial, some of them, they didn't take the treatment. We all do it. So, and it's not good practice, but we all do it. So we didn't take the entire treatment. So some of them, they didn't take the entire treatment, even though they went through all this cascade of challenges or bottlenecks that through the system. And then from those that came at the right time to the right provider, were correctly diagnosed, they took the treatment, and from those, 98%, in 2% of the cases, the treatment will not be effective. So in a sense, so you are having an intervention that is malaria treatment that is really effective, 98%. But when you bring it to the system, at the end, you get 14%. The intervention is 14% efficacious. So why this is happening? So there are a mix of factors. There are system factors. There are individual behavior factors. There are factors that are related to the provider, some of them to the user, and also it has to be with the therapeutic efficacy of the of the treatment. But we need to, so if we want to improve this 14% and improving people having access to the right treatment, we cannot think that it's only about stockouts, or only about the training of clinicians, or only about healthcare seeking behavior. It's about all of it. It's about all of it. And if we want to influence this cascade of losing traction of the intervention, we need to intervene at different points in the system. So in a sense, what we think is that, so if this system produces a 14% efficacy, it's because it's designed to produce that. If you want to change the 14%, you need to change the system. It's not enough anymore with one single intervention that will influence the entire system. And what we usually do is we tend to oversimplify. We tend to say, oh, no, what we need is to improve the supply chain. Oh, no. And it usually depends on your expertise. So, oh, what we need is training nurses or clinicians, or what we need is, and what system thinking brings you is this ability and this brings you tools and approaches that can help you understand the complexity and embrace the complexity. And it can help you in solving some of these questions, like who should I involve in my decision-making processes? Why this intervention is not producing the expected results? How do I integrate culture and values in my decision-making processes, in how I design interventions? Some of these questions can be system thinking. System thinking approaches, it will not give you the answers. It will give you a way to look at the reality that can help you answering these questions. And this is what Aku was referring with the mindset shift. So it's a different way, it's a different lens to look at reality. and we want to bring that. But what we see is that when we bring system thinking to districts or to health facilities, people say, no, but we are too busy, or we don't know to do this is very researchy. This is not my cup of tea, or you see resistance in the system. So there is a strong body of knowledge that has brought us to this point where we have tools, we have approaches to system thinking approaches to apply to health systems, but we need to do this next step of applying it within the system. And for me, this is what this webinar is about. It's about taking the system thinking tools and system thinking approaches and bring them to district health offices, and bring them to health facilities, bring them to routine activities of the health system, and use them to improve how the systems perform. And just is the last point I want to make is that complexity is there. So it's there. The fact that we don't look at it doesn't mean that it disappears. We just need to deal with it. So I just want to advocate to embrace complexity and to deal with complexity in a systematic way, which is what system thinking can bring us. And with that, I think I will stop there and hand over to Carmen.
Thanks so much, Daniel, and thanks so much, Aku. I think this was a great way of bringing us all into the same page and why we are here and where we are heading to. We have now a very short Q&A if anyone has questions. My colleague Anna Soja, who is a research assistant at SYSTAC, will be taking up any questions and direct them either to Daniel or Aku. You can, well, Anna, you can give the instructions for the Q&A. Sure. Sorry.
So no worries. So if anyone has a question, I can type it in the chat and we can give like 1 minute for that. And I think I see some coming in, or if you'd like, you can also raise your hand to unmute. So I think we have one already. So is system approach the same intersectionality approach, the same to intersectionality approach? So is that something that Daniel or Aku want to take a first stab at?
I kept trying to give an answer. So I don't know if it's the same or it is how we like to see system thinking approaches and intersectionality is we like to see them as different lens that we use to look at reality. Of course, in intersectionality there is systems thinking in a sense that you're looking at different factors. You're looking at the context, at the culture, and the norms. So that there is part of that. But we like to see it as a set of different lenses that you also need. So when you're, for example, when you're designing an intervention, you probably need to put your system thinking lens, and then in addition to that, you need to also put your intersectional lens to make full sense of reality. And there are probably other lenses that we may need to put out there. But I see this. I think they are related, but they provide different insights into what is going on in the world. I don't know, Aku, if you would agree with that.
Yeah, I would agree with that. And I would just, first of all, I'd say it's a great question. I think it's a very important question because these are issues that we're always in our modern world sort of wrestling with. And as Daniel has said, intersectionality sort of takes three particular social axes. It takes the axis of gender, it takes the axis of race or ethnicity, and then it takes the axis of social economic sort of strata. And basically says that, you know, people experience the world where those axes intersect. And so the experience of a wealthy white man would be very different from the experience of a poor Black woman by virtue of those intersections. Whereas systems thinking, as Daniel was saying, they're similar in that you're not trying to respond to your challenge by looking at one sort of the closest problem. You're rather stepping back and taking a broader look. And with systems thinking, we also have particular theories that we can draw on. We can draw on things like complex adaptive theory. We can draw on chaos theory. We can draw on ecological models. And then we also have some tools that basically say, if you have a system, instead of just looking at, you know, what sort of the behaviors of the system or the symptoms of the system, you are using systems thinking to try to diagnose what are the interactions. So a person in a system, you're looking at various things like structures, like histories, like values. Those are sort of all of the intangibles. But then you're also looking at sort of more hard things as well. So they have different theories about them, but they help us in a similar way sort of explain complexity.
Thanks so much, Aku and Daniel. So I think we actually are perfectly on time, Carmen, to move on to the speakers, and then we'll have more time for Q&A later, and you can continuously enter your questions in the chat as we go.
Perfect. Thanks so much, Anna, Daniel, Aku, and Bahari for the question. And having said that, it is indeed my pleasure to introduce two speakers, the two speakers of today, or two further speakers of today, who will be presenting experience and examples of how they have actually bridged this theory to practice. So it's going to be a really exciting, or two really exciting presentations. First, it will be Professor Joanne Okipinti. She is the Managing Director of the Computer Simulation and Advanced Research Technologies. She's also heading the Systems Modeling and Modeling Simulation Data Science unit in the Brain and Mind Center at the University of Sydney. And finally, she is the co-director of the Mental Wealth Initiative Brain and Mind Center. And she has over 20 years of experience in health service delivery and clinical research in Australia, as well as translational research to inform strategy for disease control and elimination in the Asia Pacific region. Today, she will be presenting about systems modeling and simulation to support health policy and planning, where she has a lot of experience bringing these applications that have provided decision support capability to address complex and persistent challenges such as mental health service delivery, planning, or childhood overweight and obesity. So it is my great pleasure to welcome you here today, and we are really, really looking forward to your presentation. Welcome, Joanne.
Thank you very much for the lovely introduction. Can you see my slides okay?
Yes, yep. Perfect.
Okay, great. So I'll launch straight in because I know we're short of time. So in trying to address complex health and social problems, decision makers consistently tell us that they face a number of challenges. And these won't be unfamiliar to many on the webinar. And these challenges include the complexity of many population health and service delivery problems that offer up many potential points of intervention, as Daniel alluded to. There are often a broad range of options for intervening, supported often variably by the evidence, but there's also uncertainty about the likely effects of different combinations of programs and initiatives and the interdependencies between them. There's uncertainty about how they will perform in different contexts. Service needs change over time. There's often many different perspectives on a problem and competing views on what should be done, which can prevent consensus on the best course of action and sometimes lead to policy resistance. So systems modelling and simulation provides us with a way of mapping and then quantifying a complex problem, bringing together the best available research evidence, data, and importantly, expert and local knowledge to produce an interactive decision support tool that kind of creates a safe virtual environment for forecasting the likely impacts of policy changes and major investment decisions before they're implemented in the real world. So for the past 5 years, we've been committed to taking this sort of modelling out of back rooms and into meeting rooms and exposing the work to open, transparent, participatory processes. Having a broad range of stakeholders from across the system get under the hood to critique the structure, the parameters, and the assumptions that underpin these models helps ensure that the final tool is credible, it's valid, it's robust, and it's grounded, importantly, in the local context. And it also generates greater confidence among stakeholders in the model outputs and insights and facilitates consensus building for a collaborative, more collaborative and coordinated actions. So systems modelling and simulation helped Australia successfully navigate the pandemic by providing our national and state governments with critical tools for navigating the complexity of this rapidly evolving public health crisis. And these models inform timely, decisive and effective responses to the pandemic, which saved tens of thousands of lives in Australia and is keeping transmission relatively low. And while systems modelling have long been used in infectious disease control, it's definitely underutilised in other areas of public health policy and health systems strengthening. And while my team and I have implemented systems modelling across a broad range of areas, in the brief time I have today, I just wanted to showcase the value of systems modelling by presenting some insights from our most recent COVID mental health work. So this is a high-level view of our system dynamics model of the social and economic impacts of COVID on mental health. And the model was developed by SYSTAC's partner organisation, the Brain and Mind Centre at the University of Sydney, and particularly by two talented members of the team, Dr. Adam Skinner and Dr. Nicholas Ho. And of course, there's no time today to describe it in any detail, except to say that it captures population dynamics, changes in psychological distress. It models a range of the social determinants of mental health and suicide and how they interact. It captures mental health services dynamics, and it has a suicidal behaviour component. And just to show how the model operates, if we zoom into the mental health services component, this component captures the movement of psychologically distressed people through one of several possible pathways involving potentially general practitioners, psychiatrists and allied mental health professionals, emergency department presentations and psychiatric inpatient care, community and hospital-based outpatient care, and online services. And so when we run the model, the proportion of the population waiting for services or receiving services changes over time on the based on different rates of flow into, within and out of the service system. So a broad range of sources, data sources contributed to informing the structure and parameterization of the model, which importantly includes the knowledge of people with lived experience of mental health issues and suicidal behaviour. The model was validated by making sure it could replicate historic time series data across a range of mental health indicators. And when it does, it gives us greater confidence in the model's forward projections. And we also build interactive interfaces to allow end users, often policymakers, to ask what if questions. It allows them to turn policies and initiatives on and off, scale them up and down, stagger their implementation, and test the impacts of different combinations of interventions against a baseline of business as usual. Impacts and implications are of selecting one suite of interventions over another when we're talking about resource allocation, and determining the best targeting, timing, scale, frequency and intensity of interventions needed to deliver the greatest impacts over the short and longer term. So on to some key findings. So even prior to the pandemic, the rate of suicide was increasing in Australia. And given that the majority of suicide deaths usually occur in men, and given that the temporary economic protections put in place benefited men to a greater extent, Australia was successful in preventing an overall increase in suicides in 2020. But our projections estimate that over the next 4 or 5 years, we're still likely to see a 6.5% increase in suicide deaths. While men make up the majority of suicide deaths, women are much more likely to be hospitalised for self-harm hospitalisations, which is a proxy for suicide attempts. And of the projected increase in self-harm hospitalisations, a greater proportion of that increase is among women, which is likely to widen the gender gap. So While simulating baseline trajectories of population mental health outcomes can help us understand the challenge of the scale ahead, the real value of systems models is their ability to simulate a range of possible mitigation strategies. And doing that revealed a number of important insights. The first is that some seemingly worthwhile national investments that were made in Australia are unlikely to deliver the anticipated impact. And one example is the expansion of Helpline services. The blue line is the baseline, which is the COVID mental health trajectory, and the red line, which is run 2, is the impact of Helpline services. And the limited impact is explained by the fact that when service capacity is limited and already stretched, as is currently the case here, it's difficult for helplines to link to specialist community-based services needed to deliver ongoing care. And so investments in helplines, while they seemed like a good idea at the time, on their own are relatively ineffective as a public health response to the mental health challenge. Some programs are projected to make things worse, and this is really important insight, as we commonly know in complex systems, about unintended consequences. So again, the blue line is the baseline and the red line is the projected impact of mental health awareness campaigns. Now, there's research evidence that suggests that population-wide community awareness campaigns are effective in reducing stigma, increasing recognition of symptoms of mental ill health, and improving treatment seeking. They act to drive more people into a service system. But when that service system is already stretched, wait times increase, which drives up emergency department presentations because people in crisis can't wait 4 to 6 weeks for care. Oops. Another key insight of the modelling was that some of the most effective programs to reduce adverse population mental health outcomes lie outside the health sector. So job creation programs targeted at women are the single most effective strategy for reducing the adverse mental health impacts of the pandemic in Australia. Increasing the rate of female employment initiation, coupled with the provision of affordable and accessible childcare, is projected to reduce the duration of psychological distress and start to reduce that gender gap in self-harm hospitalisations. But despite the good impacts of employment programs, large additional investments in community-based specialist mental health service capacity are required to address the COVID mental health challenge in Australia. And while the impacts of increases in health system capacity introduced in 2021 are unlikely to be seen until 2023, and don't act to reduce the peak of the adverse effects, they do have an amplifying effect over time and significantly reduce the duration of the long tail effect of COVID on mental health. So we have some interventions that aim to work effectively early and reduce the peak. Other interventions take longer to play out, but have an amplifying effect over time. So it's important to have a good mix of interventions that have those two effects. The final key insight is that the best mitigation strategy comes from coordinated and gender-informed economic, social and mental health programs and initiatives. And I've run out of time, but I wanted to end by reiterating the important role of systems modelling in testing what suite of interventions are required, by what sectors, when, at what scale, and targeted at whom to tackle complex public health problems. It's not enough to assume that just because a policy or program is evidence-based, that it's necessarily going to have the impact at a population level, as Daniel pointed out earlier. We need to understand how it will play out when introduced into a given dynamic system at a given time and under what set of circumstances. Sorry, and just I can make these slides available, but if anyone's interested in some of the COVID mental health modelling, there's additional reports available online and a range of papers on applications of systems modelling with communities. Thank you.
Thanks so much, Joanne. This was a fantastic presentation, and I'm sure there are many questions and comments, and I warmly invite everyone to start writing them in the chat so we have time to address them afterwards. And without further ado, I would like to move on to the next presentation, who is another dear colleague of us. It's Professor Shamsa Rizwan. She is currently working as a professor in today I'm having trouble, sorry. Obstetrics and gynecology at the Fazaya Medical College in Islamabad, Pakistan. She has over 30 years of clinical experience, 50 years of public health and maternal and child health research experience. And she's currently the research team lead at the Systems Thinking Initiative for District Health System that Aku mentioned before, and will be introducing some of the experience within that initiative. So sorry, Shamsa, welcome. And we're really looking forward to your presentation. Thanks for being here.
Thank you very much for this opportunity. So I'll start with this thing that various organizations and especially business organizations have been using process mapping for quite a number of years. I'm going to share with you the experience that we had using the process mapping within the district health system of Pakistan. So this saying by W. Edwards, I really like, that if you cannot describe what you are doing as a process, you do not know what you are doing. And many a times we are, when we are working within a health system, we are doing so many things at a time, we really lose sight of what the processes in reality are. So process map makes the invisible visible. It not only helps us explain, understand, and visualize all the steps of any process with graphical illustrations as well, but it also uncovers certain hidden steps that are there in a process. So I'm going to share how and why we used a process map in Pakistan. Why process map helps, I think, is to understand, instead of the ideal processes, to understand the true processes effectively. Process maps are great help. This also helps us capture the whole process rapidly with the aim that we can improve the process and make it more efficient. But one byproduct of this whole process is a very good communication that develops between various stakeholders, because once the stakeholders are sitting at a table and looking at the whole process collectively, there are so many things that are clarified, and that helps analyze a process in a better light. So the first step and I've tried to divide it into different steps, the whole process, how we used process map. So the main step is to identify the process on which we are going to work on, because as you know, the health system has many challenges, and you have to identify one challenge on which you can work with the process map. For us, we sat with the district health team in Islamabad. We had various discussions with the stakeholders, and we decided that, and it was the decision by the DHMT, that contact tracing, because this was the time when COVID had started and contact tracing activities surveillance activities were the main work that they were doing. So they wanted us to look at contact tracing and use the process map for that. So that is, I think, the most important step to identify the process. And then another step, which sometimes we think, well, everybody knows who's the stakeholder involved in a certain process, but being very naive, when as a research team went to the district health team, we thought this is surveillance done by the district health team, and that is where everything is based. But there are community health workers who detect patients and refer. There is a whole surveillance team which is working in the field. There is a central laboratory where not only the whole data of testing comes, but they also share line lists every day. Then there are public and private facilities that also collect information about COVID patients, they send them for tests and are directly involved in contact tracing. Also, there is a rapid response team that brings results from the airports, and of course, the district health office is the main hub of all the activities. So mapping the stakeholders is really important if we want to understand the process. And another important thing is that we have to really engage with I mean, I'm talking about the real life situation where without having a very good engagement with the stakeholders, you cannot get any information about the processes. So that's what we did. We had multiple meetings with different cadres of people. We developed that rapport with them. And one advantage that we had because of that was that we identified some useful resources that they already had, because they had prepared a memo sort of a thing where they had written down their contact tracing activities. So that initially helped us frame the process map. And of course, that led to better communication as well. Now, when we start developing the map, we need to identify the start point of any process. So in this particular case, where contact tracing was the main idea, our starting point were suspected cases of COVID-19. So the next question was, how could they be captured? And then there were multiple sources from which those cases were captured, from the health facilities, from the community through the community health teams, also from other sources. So we identified the start point, and then we started building this process map. And as you can see now, this is the process map that we developed. We used Visagi software, but this can be initially. So when we had these sittings with the meetings, and remember, the processes can only be identified by the team who's actually working on the ground. So we had the field team, the district management team, and other people sitting together, and we developed these process maps for each stakeholder separately. The different colors that you see here are the different, sorry, I'll go back, different organizations. Right, so this is not working probably. Yeah. So you can see this horizontal lines of different various colors are various stakeholders, starting from the laboratory, from the surveillance team in the field, and the community health workers, and all of those stakeholders. So for each stakeholder, the process map looks different. So other than identifying the stakeholders and then understanding their processes, now also it is important to look at a process in depth to know what are the main milestones. So that is like grouping together different activities. So the three types of activities that we could group together were, one that are given in green were the identification of suspected and confirmed cases of COVID. The second part was how those cases were then managed, wherever, whether they were sent for treatment or what was done to them. And then the main contact tracing activities, which involved tracking all the people who were the contacts, and then getting the tests done from there. So identifying the milestones in a process is an important step. And then, of course, when you develop a map initially, it has to be refined. This is not something that you make it once and it is 100% correct. Then it is also important to validate it with the people together, again, sitting together and looking at the process. And when we did that, there were certain areas where we made changes. There were certain changes that were made. So processes are not static. These are evolving. And we need to have regular consultative meetings with the teams to really understand how the process is now developing and how things can be effectively improved. Another important step is analysis. Now, without analysis, the whole process does not seem to be useful. So looking at it, looking at any duplications, looking at the processes that are not effective, deleting those processes, putting in more processes is an evolutionary process that should keep on happening, and that means that the stakeholders should sit and meet and discuss this. We had many challenges while we started this work, and you know that when because of COVID, the situation was such that people were really busy. They were giving much more time than what they were required to do. So in that context, it was hard for us to get them to, learn something new. But in any case, whenever you are changing from traditional methods or traditional practices, it is really a challenge unless the people see value in it. And I think finding the value is one of the most important lessons or things that I think is important if one wants to scale up, or if one wants people to really use it later, especially in the district health systems. So of course there is resources. The problem of resources is always there. Having space, having people around, getting the regular meetings of stakeholders, and of course use of technology is also not something that many of the district people were used to, though it is not essential that we only use Visagi for process mapping. So what we did was that we used a huge chart on which we wrote the different process areas, but also one can use those stick-ons or any other method that can be utilized, and then process can be developed using that. But with those challenges, I must say that there were many opportunities. So what we, I think one of the very heartening thing was that people who were working in the field, usually people do not have that time to appreciate them or even to listen to what problems they are having while they are conducting their work. So when they were involved, when they were asked about how their daily activities are and how the process looks like, so they felt involved, they felt their morale definitely increased, and that they shared with us. But another important thing was identification of the bottlenecks and pain points which were there in the system. For example, one of the delay that was occurring within the system was because the reports that were generated from the laboratory took some time to reach the district health team, and then that delayed the contact tracing process. So these were the things that were highlighted when we looked at the process maps. Then whenever one wants to switch from to digitalization, which is an important step that is happening in most of the district systems now, it is important that it is process driven. And for that, involvement of the team that is there is very, very important, and looking at their processes is important rather than, we have this technology driven digitalization. So for that also, this was quite useful. This helped improve the efficiency, and I'll give you an example of the data that was being extracted from the system or utilized or not utilized. So many of the data information that was fed into the system was asked in a way that it was not useful, or many a times it was redundant. Many of the times the information was not even fed properly within the system. So all of these things, when they came to notice, they were able to then rectify the problems. Another important...
Sorry to interrupt, just to say we should slowly be wrapping up.
Okay, so, and another opportunity within the system was to monitor the performance of the entire process, and also to define red zones for resource use. For example, when the cases were really, the number was rising up, this process map helped people realize at the policy level also that more human resource is needed at certain areas. For example, there were certain ambulances and transports were needed. So all this came out with the help of the process map. So I think this is about all. Thank you for listening. If you have any questions, I'll be ready to answer. Thank you.
Thanks so much, Shamsa, to you for such a clear presentation. So we still have a few more minutes for questions and answers. And Anna, I think you have a bit of overview of what's going on in the chat. So over to you. Thanks.
Yes, sounds great. Thank you so much both for the presentations. And so we have a few questions about technical resources that I know Daniel and Joanne already answered in the chat. So we can move on to Anna's question, thanking Joanne for her presentation and asking, which environment do you use to build and run the system dynamic model? And I'm assuming that's about when is it a good idea to run this type of model and when is it not? At least that's how I understood it.
Right, yes. So I think when the questions are about, resource allocation and decision makers, have an amount of money to spend and they want to decide, where and how to spend, I think that's a really important reason for developing, like for going to the extent of quantifying and developing these sorts of decision support tools. I did focus my presentation on the Australian example, but we are starting now to apply this work in low to middle income countries. We currently have a project in Bogota, Colombia on youth mental health and how to respond effectively to the youth mental health crisis there. And that's being part of one of the key partners of that project is SYSTAC, and we're very happy to have them as a partner. But I think it's there was a misperception that that kind of going to quantification and building kind of these sorts of complex models are only things that should be done in high income countries, or there isn't the data or there isn't the resources, I'm determined to prove that misconception wrong. We are we think that there are, really complex problems and real and important uses for systems modeling in low to middle income countries as well.
Thanks so much, Joanne. So if we can move on to the next question, just in interest of time, we have from Mike, which says, an important criticism of health systems research and practice is that it fails to take account the full range of systems approaches and methodologies. So what is being done in the community to gain a broader understanding of systems thinking and the strengths and weaknesses of the different systems methodologies? And just for context, he specifically works in systems thinking, but not in health systems. So that's kind of the background. And also, Mike, if you wanted to unmute and elaborate on anything, that would also be welcome. But if not, we can have Joanne or Shamsa come in. I think Mike is unmuting now.
Yeah, I have. I understand there's been at times a major issue, but the two presentations we had were on systems modeling and on process modeling, and they're extremely useful varieties of systems approach. But there are a whole other set of types of systems approach: organizational cybernetics, soft systems thinking, critical systems heuristics, critical systems thinking, and it seems to me that the community of health systems research would benefit in getting to grips with all aspects of complexity if it did take account of a wider range of systems approaches and methodologies. And it's not just me from a systems thinking perspective pointing this out. I know it's frequently been said within the health systems community itself.
I would completely agree with that comment, Mike. I think it depends what you're aiming to achieve and what the question you want to answer, and available resources, and a whole bunch of factors would indicate which of the broad range of methodologies would be best used. I think we should be expanding the repertoire. And educating the health community of what that repertoire is, which I think is exactly the purpose of this alliance, this group.
Good.
If I may, yeah, just because I totally agree as well, and for me the challenge, like from an outsider that I was some years ago, it's difficult to find the information. It's difficult to find all the different methods and tools and approaches that you can use in one kind of go-to place that is easy to understand for researchers, for policymakers, for implementers, for different profiles of people using system thinking. And I think that that sort of resource would be really useful, and it's part of what we are trying to build as part of SYSTAC. Like, because I see many people interested.
Quickly, Daniel, it's not. Daniel, it's not hard to find it. What we need is a closer engagement between the systems thinking community, which concentrates on that, if you like, cataloging and looking at that resource of systems approaches, and the health systems community, which is dealing with its range of problems.
Yeah, well, it's difficult to find it in a way that is sometimes it's useful for implementers, for people that they are not like working on system thinking 24/7. They are a district officer in some place in Ghana, and they want to apply system thinking. And in that sense, I still see like the need to translate some of these tools and some of these approaches into more kind of practical and easy to use and direct ways to implement in the field.
Yeah, I'd accept that.
Mm.
Yeah. And it's often hard for people to, you think it wouldn't be, but in my experience, it has been. They see an example in, say, ecology or water management, and they can't make that leap to how I would apply that process into health. So having real health examples, so having the systems thinking community work hand in hand with the health systems folk, I think having that team approach would really help with implementation. And people see it as a bit of a risk taking that kind of step unless they build those relationships and know how it's going to play out.
So I think I'll have to cut off the Q&A here and officially close and pass off to Carmen, and then we have 5 minutes afterwards if we want to continue the discussion. So Carmen, go ahead.
Thanks so much, Anna, and thanks to all for the engaging presentation and discussions. And actually, well, yeah, we are kind of straight at the top of the hour, and sorry if this was a little bit abrupt, because usually we kind of always run a bit out of time. But we can continue this discussion for 5 more minutes here in the Zoom. We can also continue this discussion in the Hive. So we actually hope that you all have said yes to continuing and participating in this online community. You will be receiving further details on how to join and engage there. And with that, I would also really like to warmly thank the Alliance colleagues for hosting and organizing the technical setup for us here, the SwissDPH colleagues for the background work, and also, of course, the Joanne and Samsa who have done amazing job in bringing these very practical examples to us today. And to all of you for joining and participating. And with that, those that have to leave, I have so many people already leaving, you're welcome to leave. And for those that want to join, you can also unmute yourself and we can continue this conversation. Thanks so much.